Good afternoon, everyone. I'd like to welcome you all to the 9th Annual Cy Frank Legacy Lectureship, and I also want to greet all of those who are our online attendees. I'm Diane Mosher, and I'm the chair of the Cy Frank Lectureship Committee, and I am your moderator for today's lecture. First, we all know that Dr. Frank loved Alberta. He loved the mountains and the rolling plains, as well as especially Kananaskis, that I feel privileged to work and play in this beautiful land that we share together. And I'm also privileged to work in Medithni, formerly Morley, and know firsthand the health disparities experienced by Indigenous peoples. I see the land acknowledgement as a reminder of our commitment as this medical school to address the health inequities of our Indigenous people. And therefore, I would like to acknowledge and pay tribute to the traditional territories of the people of Treaty 7, which include the Blackfoot Confederacy, including the Kainai, Piikani, and Siksika nations, the Tsuut'ina Nation, and also the Stoney Nakoda Nation, including Chiniki, Good, Stoney, and Bearspaw. As well, that the Métis Nation of Alberta is home to, the City of Calgary is home to the Métis Nation of Alberta Districts 5 and 6. So, housekeeping. There's just a few things. That there's going to be a question and answer after the lecture, and the lecture will be about 45 minutes and about 15 minutes of questions. That for those joining virtually, if you happen to leave the lecture, you can rejoin by signing in with the same link that you had. And if you have questions online, then please put them in the chat box and they will be monitored, and we will try to answer your question, to have your questions asked. And for those in the audience, there will be somebody with a mic that will come around and take your question. This lecture is being recorded and will be shared via email to all those registered attendees. As we know, Dr. Frank was an orthopedic surgery scientist, long-term faculty member at the Cummings School of Medicine, and one of the founders of the McKay Institute for Bone and Joint Health. Dr. Frank was internationally known and claimed for his visionary efforts to lead and champion the values of multidisciplinary clinical research and the application of this research to innovative solutions in healthcare. Upon his passing in 2015, the University of Calgary and the Cummings School of Medicine established an endowment to create the annual lecture in honor of Dr. Frank's legacy. Now, I would like to share a video that was created a few years ago, which honors his generosity and shows the impact he had on community.
It's a huge question to ask about Dr. Frank's contributions because they've been many, they've been very...
Dr. Frank was very integral in orthopedics in Canada and medicine in general.
His innovation in trying to develop new ways to deliver care, it was such a great impact on both Alberta orthopedics and Alberta medicine.
Well, I first met Cy in an interview process for the 13 inaugural scientific directors of the Canadian Institutes of Health Research.
Everyone assured me that he was a great leader, a great individual, and a great scientist. Cy and I worked closely together for the next 7 years. Me as president of CIHR and him as one of the 13 scientific directors.
I worked for Cy at Alberta Innovates Health Solutions when he joined 2.5 years ago as the CEO.
One of the lasting legacies for Cy, I think, has been the establishment of this Center for Mobility and Joint Health. The McKay Institute is a big part of that. And what Cy always believed was the power of putting an engineer together with a clinician to have that collaborative environment.
As a researcher, he had the respect of the entire orthopedic research community throughout the world.
One of the great attributes that Cy had was his ability to put it all together, to form a plan, to get people behind that plan, but then to be able to implement the plan. And that is very, very hard.
Engineering, kinesiology, nursing, rehab medicine, the hard sciences, rheumatology, orthopedic surgery. That was all his vision, and he wanted us all mixed up. He was adamant that we had to be all rubbing shoulders day to day in this multidisciplinary group.
Cy really believed that research could inform better clinical care, but he worked in the real world and he understood how he had to make changes locally, how he had to make changes provincially, how he had to affect change nationally. And that really earned him a reputation in Canada and beyond as somebody who passionately believed in better clinical care for people.
He had a really strong vision around the value of sharing health information and what that could mean for the improvement of providing services to the patient.
He struggled with some of the injury-related things that many of his patients did, and that helped him, I think, identify with patients.
I think that's what really made him who he was and why he has garnered so much respect, is because of that ability to relate to people, no matter their background, no matter where they come from, and be able to bring people together to share ideas. People felt like he was genuinely interested in what they had to say, because he was.
The lectureship is intended to promote and to make sure that those enduring qualities that Cy represented are continued, even now that he isn't with us.
I think he'd say keep going. You know, he leaves behind a real huge number of champions that are trying to make the world a better place, that are trying to make it better for patients and it better for clinicians.
And now it's my great pleasure to introduce the 2024 Cy Frank Lecturer, Dr. Robyn Tamblyn. Dr. Tamblyn is Professor of Medicine and James McGill Chair at McGill University and a medical scientist. She is the Scientific Director of the McGill Clinical and Health Informatics Research Group. And in 2011, she was appointed as the Scientific Director for the Canadian Institute of Health Services and Policy Research, a position that she held until 2018. Her work has earned her numerous awards. In 2014, Dr. Tamblyn was appointed to the Order of Canada for her significant improvements in the Canadian healthcare system. In 2015, she received the Outstanding Achievement in the Evaluation of Clinical Competence for Sustained Excellence in Canadian Healthcare and Research from the Medical Council of Canada. In 2019, she was elected to the Fellow of the Royal Society of Canada, and the same year appointed as Director of the Division of Clinical Epidemiology at McGill. So please join me in welcoming Dr. Robyn Tamblyn.
Yeah, thank you so much for that lovely introduction. And I think I can just move this on. There we go. Okay, so it's a huge privilege to be asked to do this. I was sort of blown out of my chair one day when someone called to say, would you think about doing this or email me? And I thought, wow. I had gotten to know Cy Frank on one occasion. And that was when I first started at CIHR as a scientific director, and I was enchanted with this idea of learning health systems. You could actually learn from real world data. You can actually prove things on the fly. And someone said, there's this really interesting person who's out in Alberta who's doing just that. And I thought, oh my goodness, I better go see them. And they said, oh, he's an orthopedic surgeon. I thought, no, that's not possible. An orthopedic surgeon? No, it doesn't compute. So anyway, I was making a trip out to Alberta to see the folks at Alberta Innovates, or try to talk them into partnering with me and co-spending money. And he gave me the privilege of meeting with him about what on earth he was doing. They were doing this incredible process mapping of the entire patient journey, and they were trying to build evidence into every step and try to improve that process. And so he had patients in the room, he had engineers in the room, he had operational research people in the room, and they had it all in a big blueprint. And I was just flabbergasted that here's someone who actually is trying to not only redesign, but implement and then evaluate. Just amazing. So very inspirational to me. I went to him and I said, what do you think we should be doing in this area? He said, well, he had a bunch of, at least 1,000 things I should be doing. So it took me a while to get there, but at least accomplished some on the list. But just taking us back a little bit, a step back to sort of say, you know, Canadian healthcare has been, I would say, probably an inspiration to the world. I've traveled to many different countries, many of you have as well, and Canadian healthcare, exception of course Donald Trump's United States, has been the envy of the world because we provided essential health services to everyone regardless of their means and ways. Now, it was not easy to do that. It was in the 50s, and every province, at least 3 outstanding provinces, had their own model. And so, needless to say, one of those models had to be picked, which was Saskatchewan. And so, you know, people looked at that and said, we can do this. And especially lower middle income countries who really want to see universal health care, they look to Canada for inspiration and come here to seek that. And so the one issue that we have is, where are we now? And I'd have to say that we have some challenges, and I think every one of you in this room probably knows that, firsthand or second. And one of the many league tables, I'm not really a big fan of league tables, but the Commonwealth Fund periodically every other year does a survey of multiple countries in terms of their health systems. I don't know if you know this, but religiously, and every time they've done this, whether it's to providers or patients or consumers or whoever, is number one, the country that falls at the very bottom of the list in terms of access, equity, process of care is the United States. No big surprise there. But right next to them is Canada. And so the issue is, like, what is wrong here? What is it that we need to do to fix things? I mean, we are an interesting country of at least 12 different healthcare systems, each province having their own whatever system. We can be the land of experimental healthcare for all that matters. Anyway, so the issue is, like, what do we need to do here? And it's really an issue of opportunity cost. So if you look at the UK has National Health Service. They're established a little bit before Canada went into its Universal Health Plan. And if you look at the numbers here, the UK outperforms Canada, and they have over the past decade. And they do it at a lower cost. So if you look at the price tag on this, which is about $460 billion over a decade, it really is a matter of saying, we don't, as Canadians, we don't just want to spend all of our money on healthcare, an increasing polyglot of absorption. Because if we had that, you know, 460 billion and could have delivered the same or equivalent quality of care that we're delivering now, is we could have actually done things like this. We could have funded 125 million children to go to $10 a day daycare. We could have actually sent 14.4 million people to university who couldn't afford it. Or we could have built, you know, a timely thing, $1.3 billion worth of new houses. So we have options that prevent us essentially from moving forward on some other social fronts that we'd like to. And so the issue is, what do we do about that? So I want to take us back to sort of a Donna Beatty framework of what is it we're trying to expect out of healthcare systems and what they can deliver, so we can aspire to what it is we should expect. And if you look at this is, let's say, type 1 diabetes, type 2 diabetes. This would be the natural course of the illness if no one did anything. And in fact, this is sort of the optimal progress you could make in terms of quality and length of life given modern healthcare. And this is essentially what has been happening the last decade of the safety studies, things that go wrong with healthcare. If you don't intervene, you won't have these risks, but if you do intervene, there's going to be a risk of adverse effects, which is problematic and not desirable. And then we have the contribution of health research, which is to really raise the bar. And in fact, I think that's what many of the people in this room do. They're raising the bar either by doing translational or basic research or doing applied research. So if we look at what's happening in healthcare, you see a lot of this. You see a lot of variability in the way care is being delivered. So we'll just take a peek. Here's Ontario, diabetic care in Ontario. And you can see many of these different variation studies. I'm sure everyone in this room has looked at an atlas of some sort. It says, you know, some people do better in terms of diabetic care. You should be in the Hamilton area, and definitely not in Windsor. But the thing is, you see these variations in other systems. So here's the United Kingdom, diabetic care in the United Kingdom. You see the same patchwork of some people get better care than others, and why is that the case? And you see the same thing in the United States. So regardless of the system, you see these variations in care, which are inextricably undesirable in some respects. You really want to see people get to the optimal course that they could get given the resources that we have. And so the issue is, what are these differences due to? And it's mainly due to some health system policy issues, but it's also due to clinical decision making. And so to improve that kind of situation, people need timely feedback on how things are going, not only the process of care that they're delivering as a team or as an individual, the outcomes they're achieving, which often you don't see because the person is long gone, they're somewhere else. And you want to do it comparatively to others. So what can we achieve? And there's interprovincial comparisons, which we have in spades here in Canada, if we could get our act together in terms of sharing data. And we have them inter-country, which is even more interesting, I think. So how do we get there? And this is where the inspiration for learning health systems, which I think Dr. Frank knew very well, and I think this is where he was trying and attempting and showing that you could go, not only just on let's fix this pathway for joint replacement, but embodying that in organizational structures that embedded clinical leadership and scientific leadership and organizational leadership in the strategic clinical networks. Like, I realize you've lost those temporarily perhaps, but the rest of the world has been inspired by them because they are the embodiment of what you would need organizationally to try to put in place learning health systems that in your lifetime and in your years to come can make a big difference in terms of healthcare. So when I asked him, what do you think we need, and in the list of 100 things he thought I should be doing, is one thing that came up that was really important was this, is in the healthcare delivery system, we've traditionally had a lot of very highly trained people delivering care at the front end. We've had very good administrators, and we've had people who do kind of quality assurance for accreditation. And what we're missing is we're missing people who can actually use that data, the trillions of bits of data that come day after day from the healthcare system that could be used and turned into knowledge. And we don't have people embedded in the healthcare system who can do that. There's no job position like that. So, of course, we wanted to see what else was happening, who else was doing what. And given that was the case, and the US had just created, the Agency for Healthcare Policy and Research, had just created this entity called the Delivery System Scientist, which is a person who's embedded within a delivery organization that is doing just this. They are actually pulling the data together, supporting the analysis for clinical and priority questions, and turning that into knowledge that could be used to improve care. So we looked at what do we need to do in Canada, and we said, let's track graduates and what they're up to. I met a whole bunch of really cool, very exciting students at lunchtime, and some of their aspirations were resonant to me. So if you looked at the cohort of people who were health services researchers graduating from some of these Eastern universities between 66 and 99, a lot of them went into the blue bar here, academic positions. But over time, that's changed a whole lot. Number one, there are not that many academic positions for them to move into. Universities are not exploding in terms of hiring people. And number two, there's an increasing demand from other sectors. It's government, it's healthcare delivery, it's the private sector who need these kind of, I'd call them knowledge science engineers who can actually help them turn raw data into real knowledge. And so we saw this trend happening already, and yet the phenomenon was that we are not training people to go there. We're training people to become academics. And these are the kind of skill sets. We give them research methods, how to do data analysis. We think we're innovative. We're teaching how to do knowledge translation. That's the latest pet in the array. But we're missing a whole bunch of other skills. And these are the kind of skills that we're missing. And this was pointed out to us by the community of people who were the recipients of these graduates, saying they're missing stuff like leadership, multidisciplinary work, project management, network and dialogue. They're missing all of these skill sets, which you could call soft skill sets. And this was a phenomenon not just in Canada with the workshops that we did with academics and end user employees, it was across the board, even in the US, the same phenomenon, missing key skill sets. So we rallied together two very interesting gentlemen who differed in height by about 3 feet. And they were key leaders in this area, Stephen Bornstein and Staney Brown. And they corralled together, because Staney had been in the private sector, the public sector government, so he really had a sense of what was needed here. And so the two of them together pulled together workshops where we actually said, what do we need to do to fix this, to inspire people to change how people are trained and where they go. And so they created essentially something called the Health System Impact Fellowship. The Institute of Health Services and Policy Research naturally funded this, but many other institutes joined in the field and said, yeah, this is a good idea. We need to fund it too. So at this point, I asked the team there to ask me, give me an update and where we're at. We're almost at 300 Health System Impact Fellows that are embedded, by definition, they had to be embedded in some kind of policy shop, health system delivery shop, quality shop, you name the shop, but they had to be there, co-supervised essentially by both academics and senior management in those positions. Most of them are postdocs, but there's a number of PhDs. And so this is a model I think is great. They're across the country. And in fact, we partnered with all these organizations to make that happen. So that we increasingly, the capacity, one of the key components, not the only one, of how do you create a learning health system where you can generate information, generate knowledge, and turn that into improved care is potentially possible by this new cadre of people that we're creating. So, or have created. And I think there's some even in this room who are in that roadmap of getting up to the next level. So I want to pause there and say that, ideally we're moving in that direction. There are some things I've learned along the way that I've found to be kind of important in a successful endeavor. And needless to say, for every one success you've had probably 2 failures. It goes to be the nature of the beast. This is the way it works, I've learned. So I just want to share with you some of these reflections on what does it take to be a health services researcher in this day and age, and just some thoughts about that. So the one thing that I've realized is that failure is the name of the game. You get your grant rejected, that's a success, because you really need to persist, and I'll show you why. So here's just an example. I started with this study, which I thought was kind of interesting. I was looking at potentially inappropriate prescribing in Quebec. There was reason for doing this, which I won't bore you with, but of the things that we looked at, potentially inappropriate prescribing, is you realize that benzodiazepines for longer than 30 days was, I would say, the norm, not the exception. Quebec was consuming at that point 60% of all benzodiazepine prescriptions in the country. It was a favorite drug. For Alberta, it's NSAIDs. For Quebec, it's benzodiazepines. And so we went back to the clinicians and said, this is what's going on. What do you think we should do about it? And they basically said, we don't really think that that's a problem. Show us that it's a problem. And so we looked at the literature. We didn't really realize that it's not clear that it was a problem. So unfortunately, the first lesson I learned is learn how to speak to the media. It is not good that you just simply put your paper across the floor and say, here you go, because they'll make up shit like this, and of course that doesn't help you very much in your career. So lesson number 1 is learn how to speak to the media. The next lesson is this, when you have a really good idea, we said, okay, they don't really realize that maybe the use of benzodiazepine increases the risk of injury in older people. So we'll write a grant. I led that, but there was a we in that figure, and submitted it to the National Funding Agency, not CIHR at that point, and it was rejected. So this is where persistence begins. Rewrote the grant, got back to them about all the things they complained about, and they said, really, we want you to do a validation study. We don't think that you can actually measure injuries by using this administrative data. No. You have to do a validation study, first of all, to show us that that's correct. So I rewrote the whole grant as a validation study and got funded. So it proves that, if you listen to what your critics have to say, you sometimes benefit, sometimes not. But the only trouble with this is that meant that I had to actually get the gold standard, and to get the gold standard, I had to go to at least 10 different emergency rooms and go through all their research ethics board times 10, and also go to the director of professional services, which is the head of the hospital, in charge of the medical charts. And then if I wanted to link it to the administrative data I was going to use to measure injury, I had to get the RAMQ, which is our public insurer, legal counsel, and then the RAMQ's leadership to agree, and then the Freedom of Information people to agree. And so all of that took time. You can see time is passing. I started in 1992. I'm now up to 1995. And eventually, going to research ethics boards means you're going to have at least 10 different critics about what you're doing. And so it had to fix all of that. And then finally got to go to the hospitals to do pull the grants and pull the charts and enter the data. And then realized there's some missing data. We entered into a database, went back with more data. We're now at 1996 and wrote the program that would link this all to the RAMQ, send it up, the data up to RAMQ. They link it together and away we go. So in fact, we had to wait in line to have our thing processed. And they ran the program. We realized there was an error in the program. So we went back and waited in line to go back again after we fixed the program. And eventually we got new results, and eventually we published the paper. So that was a period of 8 years of just getting this stupid validation study done so I could get the grant I wanted to begin with. In any event, it just says that, and here's the data. When I got to CIHR, I actually wanted to look at the actual data because there were a lot of complaints from our community about the quality of peer review, or all the things that they didn't do well and so on. So I looked at all the data and looked at all applications, and we looked at people who were submitting applications, the new applications and resubmissions, and you look at funding rates for all applications. So look, the message is pretty clear. If you don't resubmit your grant, guess what? You're not going to get funded. And that's particularly true in health services research because there's always something we want to fix. We don't want to give you the money until we fix this last little thing for you to do. And if you want to look at sustained funding, in particular, if you don't resubmit, we have researchers who resubmit and those who don't, is you will never get sustained funding. So the message here is that you need to be persistent, you need to embrace rejection, and actually kind of listen to what the reviewers have to say and actually accommodate what are sensible comments. The next lesson is really started to get out of the box in terms of solution finding. And so here we had the situation, back to the original study that produced that weird Globe and Mail thingamabob, is we looked at predictors and we realized that one of the predictors of inappropriate prescribing is the fact that people had many different prescribing physicians. So by the time you're at 9 prescribing physicians, 100% of people had some kind of potentially inappropriate combination of drugs. And if you look at how many people had more than that, it's about a quarter, almost a quarter of people. So now, mind you, this is, it's Quebec, so there's a lot of specialists to primary care physicians, but people had a lot of different physicians who obviously weren't communicating with each other. So that was problem number one. So we looked at possible solutions and realized that in the process of trying to get rid of the back office kind of administrative problems, is that the public insurer actually said, I want to go and do an online adjudication with all the community pharmacies. Now, you guys will think this is pretty old, but this was back in the early 90s that this was going on. And so we want to, as soon as they're dispensing a medication, we want to say it's eligible or not, and we'll record it and blah, blah, blah. And that way we get rid of all the paper stuff. And so we said, that's really interesting. So that means that this public insurer at any given minute in the day knows exactly everybody that they're insuring, what drugs they're on. Whether they covered them or they didn't cover them, they know what drugs they're on. And so the next thought was, after 99 trips to Quebec City to sort this out politically, is we said, why don't we connect that information? Now think European today, but this is a decade ago. I'm so envious. We still don't have one in Quebec. Anyway, an aside. Link that, and so that the primary care physician who's actually managing these people has a picture of what's going on. And so they agreed to do that. And so we actually pulled real-time information from essentially this Teradata system in Quebec City and said, well, let's show them the following. here's a drug you prescribed, Centrum, vitamin, and it was never filled. Here's Coumadin, which is prescribed by you and it was filled, and this is the day's supply. And here's metformin that was prescribed by another physician who you may or may not know about. And here's the supply for that. And we thought we better throw in medical services data that said whether they'd had a hospitalization or ER visit just for that. And this thing was very successful, I have to say. What we discovered first off is that people looked at that. They went in, made an effort to access 3,000 passwords to get into that system, to actually look at it. And who did they look at it for? First, people who were on a lot of drugs. That makes sense. But second, people who were less educated, where it was harder to get a complete history from them. And so that was the good news. It was an equity merger in some sense of reducing inequitable care in terms of access. And the other thing that happened was that, in fact, in terms of, we ran a randomized trial of this thing, is it actually reduced, during the course of the study compared to the 2 months before, reduced the rate of inappropriate prescriptions, which is good news, because a lot of that was being created by misinformation or not enough information. So good news about that. On to the next lesson, and that this is often debated by researchers in my academic ivory tower. But that cool questions actually often come from the health system itself. So super interesting questions really do come from the day-to-day delivery front, whether it's the clinician at the front line or the policymaker or the manager or whomever. It often comes, or the consumer. It comes from them. So one cool question that we were asked to resolve is Quebec instituted a policy in the early 90s to try to provide complete drug insurance for everybody. And the way they did that, they said there's 1.5 million people are not insured. So what we'll do is we'll add co-pays to every prescription that you pick up. And that way that will be able to afford providing insurance for 1.5 million people. Brilliant idea, aimed at social equity, great idea. The difficulty was that they said, oh dear, there's something very wrong going on here. We're seeing a very big reduction in the number of drugs that are being dispensed. So they asked us if we would take a look. And so we gathered together what I call the Noah's Ark of investigators, which is 2 biostatisticians at the top, 2 economists in the middle, and of course 2 epidemiologists at the bottom of the pile, per usual. And said, let's put together essentially a program of research that will allow us to answer that question. And so we looked at that, and in fact, what was interesting, and this is a time series that was there, is that particular for the welfare population, but in both, there was a fairly drastic reduction in things like antipsychotics, insulin, oral hypoglycemics, antihypertensives. So what we call the essential drug sets. So that was a concern. And then the next question is, particularly in the income security population, is that actually increased the number of hospitalizations and ED visits in this post-policy period, particularly for welfare recipients. And for people who had major mental illness, it increased it by 5 or 6-fold. So it was a fairly major impact. And the coolest thing that ever happened to me doing research like this is that we provided this report to the ADMs and ministers of health at the time, and the policy got changed for people who are on income security, so that they had free medications again. So it's kind of a good news story, particularly for people who are already disadvantaged. Another interesting thing that I've learned along the way is that oftentimes innovations happen at the interface of scientific disciplines. In this case, there were 2 schools, I'd have to say. There were health services researchers, and there are people who do medical education research. And those people actually don't talk. They do their thing. Maybe I'm mislabeling someone inappropriately here in this audience who does, but at that time they were really not talking together. And so the research got kind of circular in a sense, is that you weren't really looking at things that determined how people practice. You made certain assumptions about it. And these are the kind of assumptions that they made, which is, if I can look at it, is that there's a whole bunch of things that happen that, Calgary's a unique, innovative curriculum, 3 years long, whatever, a small group, problem-oriented curriculum. And we introduced one of the first in the world kind of performance-based licensing exams, and postgraduate training has to occur in a certain way. So there are a lot of assumptions along the way about how people should be trained. And yet there's some pretty big links, because there's a lot of assumptions made from the medical education world, and you could take any health professional and stick them there. And yet you don't really know whether that actually predicts how people practice. And you don't know whether that practice influences outcome. So those were kind of the weak links, and that's where health services research is. So you needed to be able to link those two together to figure it out. So we actually got on board a bunch of partners, and we actually worked through this very elaborate way of actually getting their undergraduate experience, their medical school, medical council exam scores, and link that all to the College of Physicians in Ontario and Quebec, and then link that essentially to look at real practice patterns in Quebec. Not possible in Ontario. I'll get that another story perhaps at dinner as to why that didn't happen. But anyway, neither here nor there. So that happened, and the thing we learned, and this was a complicated, to this day I can hardly repeat it. What we learned is that the scores people achieved on the medical council exam taken at the end of medical school were highly predictive of the following: mammography screening, consultations. The higher your score, the more likely you're going to consult. If you actually were at the bottom of the pile, you didn't consult with anybody. You never made any referrals. And then what we call contraindicated prescribing. So you can see it went in the direction you would expect it to. But the other thing that was interesting is that they were measuring communication in a standardized way. And actually that communication score that people achieved in those performance-based exams, highly debated by the way, and now abandoned, actually predicted complaints to licensing authorities. So you can see the higher your score in terms of clinical decision-making on the left, communication on the right, the lower your rate of complaints later on when you're in practice to medical licensing authorities. So it was kind of a win-win situation of making those linkages, and there's been research since then that's actually supported that kind of connection, and it has implications, I think, for how you train people and how you construct what I call protect the public kind of evaluations of their competency at their practice. Finally, or not quite finally, I'd have to say teams are needed to handle complex problems. I think probably everybody in this room knows that. One of the most complex problems is the transitions in care problem, going from hospital to home and back again. And one of the interventions that has been highly recommended, and is a requirement actually for hospital accreditation, is medication reconciliation. And yet it's done in something like, I don't know, maybe 10% of discharges, if you're lucky, and probably 0% in surgery. I shouldn't say that. Maybe it's 5%. And maybe on Dr. Frank's board it would have been 100%. But anyway, so in fact, there's a cost there, because people who transition and get into trouble, a lot of it medication related, are more likely to be rehospitalized. And that in turn is about $2.6 billion a year. So here's a saving opportunity for reducing harm and actually improving essentially the wealth of what we can do and use for other social programs. So we built this, and I say it requires a team, because we realized that people who do, let me just go backwards, people who do this kind of job, there's pharmacy techs, there's pharmacists, there's residents, both medical and surgical, there's nurses, there's pharmacists, and everybody has to be happy. So building software that makes everybody happy, so it makes it easy, so we preloaded from essentially your PIN network, all the community drugs, we loaded up all the drugs from the hospital, a drug information system, aligned it so people know when it's the same drug or it's in the same therapeutic category, organized therapeutic categories by importance, and then put an action bar in here saying, do you want to continue it, do you want to change it, do you want to stop it, and ask for a reason. So that produced essentially a discharge or transfer prescription. So what was interesting there is by just making it easy to do the right thing and not have to hand enter all of this data and go find it, is in fact it increased completion rates for medication reconciliation to 88% in intervention units. We ran a trial naturally, 46% on control units, and actually it reduced kind of any kind of medication discrepancy. So this is a medication that was started that was never filled, a medication was stopped that was filled, and a dose change that was made but was never actuated. So the good news is that when you work in teams like that, and required that team to actually mobilize everybody's perspective, and then put it into practice, pilot it, and then finally roll it out and run it as a trial. So it takes time, and it actually takes a fair bit of funding actually to do that, and I don't think you can do it without partnerships in the health system itself to make that happen. So if you look at CIHR data and you look at essentially health services research, here's your odds of funding. If you have more than 5 people on your team, the odds of funding are dramatically better than if you only have 1. And that's compared to all applications, where if you have 1 person, your funding rate is about the same as if you have 5. So I'm saying for health services research, and I'd say population health research is in the same boat, maybe clinical research as well, is that you really do need teams to make it happen. And you'll be rewarded as such by having an increased likelihood of funding. And finally, I'd have to say the untapped resource in healthcare, and I've learned this, I'd say probably slowly in life along the way, is patience actually. People who had that lived experience can tell you a whole lot about what they need and what they want and what's important to them. I think Cy Frank knew this all along and had patient navigators as part and parcel of his care process. Really innovative at the time, really innovative way back when. So, but it's really become in vogue, you know, empowering patients to be part and parcel of the intervention. Many of you know this and are engaged in this game. The whole CARET program to improve what I'd say social determinants of health, essentially a software program that rewarded you for healthy behavior and penalized you for not so healthy behavior adopted by the federal government. And here's, you know, Amazon. I mean, grossly as brilliant ideas about how to get consumers to do the right thing. So very brilliant. So we thought, okay, well, if we have this issue of patients discharge, high risk at those transitions, and we realized that in the pool of patients that we have access to in a tertiary center, on average, they're on 10 meds when they leave. 7 of them have been changed. 4 new, 1 stop, 2 dose changes. Non-adherence to those changes is 44%. We could track that forward through time. In the first 30 days, not adherence, 44%. Maybe because no one told them. Maybe because it was lost in translation between their care team and the pharmacy didn't know, so they just said, I'll follow everything you did before. So we asked patients, what is it you need? And that increased the risk of ED visits when they didn't adhere. And so the patients told us this. These are the 3 things we want. Number 1, we want a medication list organized by what I'd say the indication. These are my heart drugs, these are my blood pressure drugs, these are my diabetic drugs. We want to have a picture of the pill because we get quite lost on what color the pill is, what the shape is, and that's how we often remember those medications as what their color and shape is. So we want that, and we want some details. If we want to have details, we would like to have them accessible to us by just clicking on that drug. We know more about it. Number 2, and I was a bit surprised by this, they have a strong belief in wanting to know about drug interactions. I thought, like, oh my God, there are 34,000 different drug interactions, but they're very keen about that. And the other thing they're more even keen about is the fact they want to know, I've developed a headache today, and I want to know whether any of my drugs may be responsible. So they want to be able to enter in their side effect, which we created this, enter your side effect, and then it will tell you what drugs produce that side effect and what's the likelihood it would produce that side effect. So they loved that. That was great. And the third thing they wanted is they wanted to be able to text communicate with the pharmacist. So whether it's the community pharmacist, the hospital pharmacist, but they want to be able to text communicate with them. Now, maybe if you're dealing with a 90-plus population, they're probably not into text communicating. But for the people that was the pool we were looking at, which are in the 50 to 70 range, you know, they were keen on this. And 3/4 of them were very, you know, smartphone savvy. So I just want to leave you with, I think there's some really great innovation opportunities moving forward. Disruptive technologies like some of the things that I've shown you already, you know, that can be used to improve healthcare are increasingly there. And I think the latest disruptor on the horizon is AI and generative AI. I mean, that's going to be really interesting. Medicare in the US is already being confronted with how do we pay for AI-enabled interventions. So that's already in the books already. So I think you're going to just see an avalanche of both good stuff and not so good stuff coming through that area. And I think new ways of doing research are also going to be embodied in that. So I think we will be soon past the idea of creating manually collected, pristine cohorts of people and data, but the data is so rich within the healthcare delivery system that is now increasingly structured. I saw Epic today for the first time. I was so impressed with what was there, the kind of detailed, granular data you have. It's just, I'm moving to Alberta tomorrow, just because that's so exciting. So I think that will produce a different way of doing research, very timely, ongoing collection with maybe minor supplementation of routinely collected data to get the one snippet you really want. And Columbia University Health Center did just that. They said, we've got a very robust health record. They probably have Epic as well. And they said, I really want to know this piece of information for that person at this point in time. And they actually create a flash up, little pop-up window saying, do they have a fever? Or, you know, please check their blood pressure. You know, so that if there's information you really need to make your algorithm run, is you can actually push it forward and request it and get it back to you. So I think this will mean that we'll do things very differently, and it means that we'll be able to do them much more rapidly. And it's kind of an exciting time, quite frankly. So I just want to say, I think it's opportunities like that we're seeing and are seeing now that will make it possible for us to do really innovative things. And I see Alberta is very poised to do some of the most innovative things possible because you have the best data in any Canadian province, and you have an abundance of really clever health services, clinical and policy researchers. Courtesy of the legacy, no doubt, of Dr. Frank and others that have been there, but he has been very inspiring, certainly to me, and I think probably to many of you. So thanks for this privilege of being able to speak to some of these issues. Thank you.
Thank you, Dr. Tamblyn. There are questions now, so I think we're going to have about 15 minutes worth of questions. And I want to thank you for your talk and sharing your pearls of wisdom with us and experience and how you look forward to the future. In terms of the questions first, are there any questions from the audience? And there's a mic that will go around. Yes. There's a question in the front from Doctor. I think you'd have to come back up. Robyn,
I have two questions, and they're regarding to two of the barriers that you alluded to in your journey. One is, who were the people that were less likely to reapply for grants and therefore unsuccessful in sustaining funding? And the second one is related to the barrier to use that valuable healthcare information. How do we break down that barrier?
Oh gosh, okay. These are both excellent questions, by the way. So who is the person who is not likely to reapply? It's usually the first time they've come to, at this case it was CHR data, first time they've come to CHR, and they get discouraged. They're rejected. They get a score of 3.2. They have people making some constructive, some nasty comments, and they get totally rejected, and they don't try again.
Are they clinician scientists?
Yes, they're
much
more likely in my mind to be clinician scientists. For clinician scientists, you have an array of possible things that are brilliant that you can do in your life in a variety of different roles. And so as soon as the research door closes in your mind, first time through, they slap me in the face. I don't want to go back down that pathway. For people who are, multitasking and highly successful, it's sort of like I'm turned off by that. And I think that boils down to mentorship, expectation, mentorship, helping people when I look at, we instituted Johnny Come Lately, grant reviews by more senior investigators for people who are just brand new. And that helped a lot because some of the things, it's a little bit how they sell their story, so to speak. I think the kind of salesmanship, it's one thing to have a great question and so on, but there's a bit of a selling point as well in terms of getting the person who's reading it as excited as you are. So that's number one, certainly as clinician scientists who are more likely. And your second question was?
The barrier to get at all of this fabulous information
shit, man.
that you think we have in Alberta that we can't actually access either, but
I think what you need to do is you need to replicate Tim Murphy and send him around to all the Canadian provinces. I mean, it's been one of the biggest struggles because we have administrative data, and that's population coverage, typically 100%, with the exception of a few pocket groups, which is to the envy of anyone. You can study an entire population and what they're doing. Envy of anybody. To get that data is the slow-mo, oh my gosh, the kind of barriers you have to go through. I mean, Quebec, I've finally given up on them. I'm just not going to bother getting any more data from them because they've gone into another weird policy mode. I have to say Ontario has showcased what they can actually do, which is making their data available to the world. It's unbelievable. Now, it's kind of crappy data compared to Alberta data, just to say. But it's really the information acts that you have, probably as importantly, who interprets those health information acts in terms of the safeguards and so on. The middle level custodian who's become extremely risk averse and in a very powerful position for slapping it down and sort of saying, no, you can't have age. Why would you want age of a person, That will identify them by knowing that they are 29, And so there's that barrier. Now you're talking we're 8 months in and the various paper things I have to fill in. And then it's idiosyncratic, It goes like this in waves. If you look at any given province, BC was another province that had incredible data. And suddenly the door got shut. And as you probably know, there was a little political hoo-ha over that. So I think it's really having the leadership and a Health Information Privacy Act that is interpreted with a balance of risk and benefit by people who can see the value of having that data used. There's no point in just it's sitting there. So I have to say at the moment, the provinces that in my mind are the furthest ahead are Ontario and Alberta. And if you're in Alberta and you say my data access is shit, well, come on to Quebec. I think that's it.
Are there other questions that we have? Yes. 2 questions, one behind. Thanks.
I was interested in your discharge prescriptions. From a clinician's point of view, if it could be added to the patients, the non-prescription interactions that people get over the counter of supplements.
Yeah, in fact, that was really what they wanted to know because, we've looked at drug interactions and, turned that into decision support at the front line for primary care. And for every given patient you see, there's at least 4 drug interactions. So that was like, turn it off, turn it off, turn it off. And every pharmacist, by the way, is doing the same thing, turn it off, whether it's First Databanks or some other database you're using. But the patients really cared a whole lot about, I'm going to take this over-the-counter drug, and I want to know if it interacts with any of the other things I'm taking. So it empowered them to have that tool right in their hand, so they could enter the drug, and they would know right away there was a drug interaction. So they weren't as interested, and we hummed and hawed to show them the drug interactions that we knew were there. And I'd have to say they're based on certain severity expert opinion, not evidence. We decided that we would show them anyway, but their real interest was in over-the-counter drugs versus prescription medication. That's where their interest was. If that is does that surprise you? It does? No, okay.
Thanks for your talk. So I'm a fan of audit and feedback, but it's still only, if you do it well, it maybe increases appropriate use by 10% or so. Deprescribing is really difficult for inappropriate medications. You have to spend a lot of effort supporting people to come off of medications like the benzodiazepines. Thoughts on how we might prevent people from getting on medications that we don't want them on? Any successes you've had?
So you're talking about like patient empowerment tools or prescribing tools or both?
How we pay physicians and anything that you're keen on.
So we started with primary care physicians because 80% of all drugs are prescribed in primary care. And in order to tackle that issue is we had to computerize at least part of what was happening, and that was the drug management part in primary care. And so a couple of things about that. One is we created alert systems based on expert consensus. And one of them was like the benzo gray in 30 days, they didn't believe the rest, blah, blah, blah. And so we said, okay, well, let's just unleash the standard drug databases to them, and we won't customize, or we won't whatever. And that's when they got on average 5 alerts per patient. They just said, shove this, man, just shove it. You're slowing us down, and I don't really care. And they're not smart. They don't say, oh, this person's been on these 2 drugs for the last decade. They're not smart like that. Those systems are really kind of dumb systems, and we believe, we talk ourselves into the fact that we're saving lives. We're not saving lives. They just turn the system off. If you look at, nonsense alerts or hyper alerting, it's that really drives people crazy. So we're not smart about it. So after that experience, devoted 5 years to that, then we got into this idea, well, maybe what we should do is that we should provide more evidence-based alerts. Well, I could be here, and my children could be here, and my children's children could be here studying that issue forever. So hopefully it's a more collaborative, combined experience worldwide. But we started venturing into the whole issue of risk of injury, because it's just a high, it's a disabling thing if people break their hip. They sometimes never get out of hospital, they go to nursing homes. So we said, let's go there, and we know they're on a lot of psychotropic medication, opiates, and blah, blah, blah. So why don't we create some predictive models? We had a big population of 500,000 people. Let's look at predictive models for injury related to their drugs. And then we'll look at all the other stuff that you can't change, their age, their sex, the fact that they, whatever. And so then we took that and we said, okay, well, let's show modifiable risk in a thermometer. So we say, here's their risk. So they have a 10% chance of having a fall-related injury in the next year based on their age, their sex, their comorbidities, and so on. And you're adding to that another 20% based on the fact they're on, oxycodone, they're on 3 antidepressants, a long and short-acting benzodiazepine, and 2 antidepressants. So we'd highlight those drugs and we say, in order to reduce the risk, you just need to reduce the dose, or you need to reduce the number of drugs, right, that they're on, or take some of those off. And in fact, that worked. That worked. And it worked in a way that you probably would imagine would work. These are guys who see people on average for 6.5 minutes. It worked for people at high risk. So as soon as the risk was high, they would do something. But showing them that in that risk thermometer, here's your modifiable zone, these are the things you can do. You prescribe some of those drugs, maybe not all of them, but if you want to actually reduce the dose in some of those, and that's what they did. They actually reduced the dose, so they got rid of those drugs for high-risk people, and that's exactly what you want people to do. Focus on the people who are most likely to have this bad outcome. So, but it was successful in the statistical sense, randomized trial sense, but it still didn't get rid of the majority of the problem. So then the next step was, well, maybe should we inform patients themselves about the risk? Well, that's kind of a territory you don't want to head into without, a lot of, security blankets on top, because you never know what's going to happen, right? Or maybe you do, I don't. Anyway, so a colleague of mine, a geriatrician, said, I'm going down that pathway. I'm going to show people that some of these drugs they're on are not useful. This is Kara Tannenbaum, in case anybody knows her. But she went down, I'm going to empower patients to understand the drugs they're on, why they're there, what the side effects are, what the problem is, and she did it in cognitively appropriate ways. And she was incredibly successul at getting people to go to their docs and say, I don't think I need this anymore, this sleeping pill. And then what she did is she said, okay, well, that's a 15% absolute reduction in that, but I can do better. So and then it was a joint pharmacist consumer approach, and she added another 10% to that, published both papers in JAMA. Her toolkit for de-prescribing is now ubiquitous around the world. So I think tackling prescribers and consumers and dealing with the dumb stuff of fragmented care, you don't know what each of the other players is doing, by providing comprehensive information. You have all the information in Alberta to do just that, I think that's a solution. It will at least tackle a lot of the problem, in my opinion.
Thanks.
Karen.
I have a question here from the online audience. And someone is wondering, in your experience, what's the best way of taking all this evidence and implementing it, making policy changes or healthcare changes?
Okay. I can answer that in 30 seconds, right? No, I can't. So how do you implement something like this? Right, okay. I think people at the front line definitely want, the goal there is make people better, reduce the risk whenever possible. And so I think you have all the right skill set right at the front line, right? You have that. Now it's a matter of get that to people in a way in which you don't slow them down in their day. They find it valuable. You risk stratify, so you're not saying, I've added another, let me see now, 45 minutes to your day, which certainly someone reported we did in terms of the number of things that we asked them to do. So risk stratify, which should be evidence-based risk stratification, meaning go for the things that are the low-hanging fruit that will produce a kind of an immediate effect. So don't provide them with 1,000 guidelines and 29,000 alerts, but risk stratify to say, here's the thing we think it would be valuable to do. And I'd say engage the consumer and their caregivers when that's relevant to say, let's just get everybody, get the message out. And in fact, that can be done. I mean, here you have you have a province-wide electronic health record. You have the capacity to reach not everybody in the population because it doesn't cover some of the private clinics and so on, but you have the capacity with strategically smart, stratified by risk decision support, you have the capacity to make everyone aware and able to respond to that risk. And making it easy to do the right thing by virtue of here's a kit that will help people think about stopping, you can add some of these frills to that, you have the capacity here, the infrastructure, to blow the world apart. You really do. I mean, how many guidelines you have to read, like 1,000 up here. You need to strategically take that out and decide what's really the goals, priorities you want to go after. Where's the greatest harm being done that's modifiable? These are great epi questions. As a counting person, I love that. So those are that's where I would start. Because you're not going to get everything done all the time everywhere, but you have to assume that everybody's here to do the best thing possible. Tracking outcomes and seeing, that person, the first thing when we provided people with, this is a little story on the side, but when we provided people with information about all the drugs that are being prescribed by different prescribers, it shocked some primary care physicians. They realized they were writing prescriptions that were never being filled, ever. They would go and stop a sleeping pill, and the next thing you know, 2 days later, the sleeping pill's there from another prescriber. So giving people the information to do the best thing possible and helping them risk stratify if it's not already obvious from clinically speaking, and allowing them to track their outcomes and see how successful they are, I think it's a great start, and you have all the tools to do that here. You know, I'm waiting to see all the exciting things that are going to happen, if they're not happening already. Hope that answers that person's question.
I think we'll take one more question, one last question.
Hi. So I found it super interesting when you talked about the life cycle of data and data application and research in the whole like healthcare system. So, but I've noticed that a lot of the times when someone or a group comes out with a standard to unify all these competing standards, what ends up happening is that they create a separate competing standard. So I'm wondering, do you have any experience maybe like not like creating some solutions, but then also trying to get everyone on the same page and using that solution, like especially across like different provinces and things as well?
You're talking about standards for EMRs, for example?
Yeah, for example, like
okay.
the database for holding medications and things like that.
Yeah. That's a really interesting question. So I can just comment on how others have done that. And I think we're at a different point probably. So what did some of the European countries in the UK do? They said, okay, we cannot standardize everything, you know? So we're going to have a common, single, one profile, critical things that we need to know. That's what we'll standardize for everybody. And all the rest of it, well, we can't do that. So we're just going to take a very common core thing that you will have and will be standardized for everybody. So that was the way they handled it. Canada said, we're going to create a standard that's going to be the most exquisite standard in the world. And we're going to tell people this is the standard that we're going to use. And it was above the grade. It was fantastic. It was great. But no one implemented in any software, right? This is the bit of the problem. So if they didn't implement, there was no incentives to implement it. The provinces had to execute. So that didn't work either. So pronouncing the standards up here, you're not going to work. Incentivizing software vendors to incorporate them, I'm not sure that that's going to work. The Office of the National Coordinator tried to do that in the United States, and they didn't succeed even though they put billions of dollars in it. So I'm not really sure that's possible. So this common set of these are the things I want to standardize is really the practical thing that people have done that said that at least we'll know this about everybody. That's pretty critical. But now, in fact, when we looked at doing this with our computer science colleagues, they said, nothing. We just use NLP and we can now structure all that stuff. No problem whatsoever, you know? So I think we're in a different era now, so that in fact, forcing a standard to the front end user to make them do it, I don't think that's going to work. You know, menu drop-downs are one way of doing it in terms of electronic health records, but the back end, so much as transcribed, dictated, blah, 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 is using NLP to structure that. I think we're past imaging reports. I think, you know, at least computer scientists sometimes can be a bit arrogant, but I think we are probably in a different world now in trying to achieve that. But trying to standardize all the data in the ocean, no, I don't think it's going to happen. Not going to be terribly useful. So the critical element's the most important in my mind. Thanks everybody for being so interested and such great questions. Thanks.
Well, I'd like to thank you. And on behalf of the Advisory Committee, the McCaig Institute, Alberta Innovates, the Calgary Alumni All Access Fund, and the University of Calgary, I'd like to thank you for being this year's Dr. Cy Frank Legacy Lecturer. And so we have this gift to present you.
Thank you.
You're welcome. Thank you. I'd like to thank the Cy Frank Lectureship Committee, the McCaig Institute, and the entire operations team for planning and hosting this year's event, and also the family, friends, and colleagues of Dr. Frank who generously contribute to the Cy Frank Lectureship Fund. And without the generosity of these people, we wouldn't have today's event. And we do continue to take donations to ensure that the lectureship can continue on. Next year is the 10-year anniversary since Dr. Frank's death, and we're planning to do a special event in that honor next year. So stay tuned. And finally, for those attending the lecture, both in person and virtually, please share your feedback on the online survey that you will receive by email. And we will now have a wine and cheese reception in the hallway downstairs by Hippocrates. Thank you, everyone.